This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
Welcome to the second workshop for this afternoon. I'm Liz Wenghofer, and I'm from Sudbury, Ontario. And we're putting this workshop together for you. Dr. Bill McCauley from Toronto and Dr. Norcross from San Diego and Peter Bohl from San Diego will all be working with you this afternoon. So just to give you an idea of what it is we're going to be doing, within the agenda, the way this had been described has been really to brainstorm on how we might create an assessment battery for the aging physician. And some of the things that we were going to include are as listed here. We talked really about when to start somewhat in some of the intervals. We've heard some discussion on that today. We got a little bit of evidence from some of the presentations this morning to help your discussions in that area. Item D is what clinical environments should require assessment. I think we're sort of starting from the premise that most clinical environments, if you're seeing patients, chances are that environment, you should have assessment within that environment. However, what that assessment looks like may change. In terms of ownership of the results, I think that's a fairly contentious issue, and it really depends in part on the purpose of what the assessment is. So again, let's think about that as you're going on your discussions. But the areas that we really want to focus on are what is it that you're going to measure, what instruments do you plan on using, and we'll talk a little bit also about the costs of some of those different instruments. So when you leave here today, we hope that you'll have an understanding of the importance of defining what it is you want to assess, or really the purpose of your assessment, and how that factors into what you do, to understand how different tools measure different aspects of performance, to understand some of the pros and cons of those different tools, as well as the importance of assessing cases on a case-by-case basis and then matching the tools to what you need rather than starting with tools and seeing what you can do with them. So what we're going to do today is, after I finish this brief overview, we'll move into some case studies. And Bill will go through those. We'll describe the cases. And then you'll break into your small groups and discuss them. And we'll have you report out. If we can have someone be a note taker and have someone elected as a foreman to be able to report out, that would be very helpful. And we'll go through two very different scenarios. At the end, we'll have a facilitated large group discussion, as well as going over some of those multiple choice type questions that you used in the first workshop. So I just want to start off by mentioning something about performance. I mean, obviously, it would be really fabulous if we had one method of assessing all aspects of performance, whether it's in the aging physician or any other physician. But unfortunately, that's not the case. And really, there is no one measure that is sufficient to measure overall performance. It is essential when you're measuring performance to understand why you're doing the assessment. What is it that you want to evaluate, and how are you going to do that? And you really need to pick the right tool for the job. And in doing so, it's exceptionally important to understand the limitations of each of those tools so that you can make sure you have an understanding of exactly what the limits are of what you're trying to assess. In terms of why, defining the purpose, the way the assessment will look will vary greatly dependent on why you're doing it. Are you evaluating the physician because there was some sort of critical event that has led you to believe that there are issues of competencies? Is this a routine assessment, part of a hospital quality assurance plan? or perhaps a proactive assessment if you're looking at potentially wide-scale screening. Is it voluntary? Has a physician come to you saying, you know what, I think I might need a little bit of help and I need you to help me figure out where my weaknesses are? Or has it actually been ordered by an external body? And based on that, the way that you evaluate the case will vary. In terms of what you're going to assess, clinical competence or clinical cares of processes seem to be the target area in the majority of the literature, and it's certainly an area of focus. It's a very high-profile aspect of performance. It's often very tangible. Given the other areas of performance, it's often one of the ones that it's a little easier to measure. There are registries, there are records that provide you data in order to evaluate clinical care processes. However, there are other aspects of performance that are important, and these are just listing a few of them. Communication skills, knowledge, there's team function, professionalism. And when we look to the ACGME and the Royal College creating the CanMEDS roles, we really see that the national bodies have recognized this, in that they have established a series of competencies that really look at more than just clinical care. So, you know, as we're looking at medical knowledge, patient care, communicator, professional, collaborator, these are all things that the national bodies have indicated to be important for all physicians to have a measurable level of competency in. So we can use this as a framework as we go forward to thinking about how we're going to assess physicians. Now, I won't be able to go through all this, and it is this whole table is in your conference package, and it's taken from a publication by Dr. Norcross and colleagues. And the point of showing you this is when we're looking at assessment tools, the majority of tools are really designed to look at specific aspects of care. So once you know what it is you want to measure or what it is you want to assess, then you can start to evaluate what are the tools that are available to us. If you start with the tools first, it's kind of like having a hammer, and after a while everything looks like a nail. You'll try to actually use those tools to assess different aspects that it never was designed to do. So just to give you an example, if you're looking at evaluating patient care, you can see that there are a lot of great tools. Chart review, physician interview, direct observation, all those things give you a glimpse of the type of patient care a physician provides. However, using patient surveys, satisfaction surveys, won't give you a particularly good or valid reflection of patient care. However, if you're looking at something like interpersonal care and communication, then your patient surveys do give you a fairly good indication of how well a physician is able to communicate. However, your chart reviews in this case aren't really great at providing you any sort of information with regard to how well a physician is able to communicate. So again, once you've identified what it is you want to actually measure, then you can try to match up the right tools for the job. Obviously, each of the different methodologies have pros and cons. For example, and again, unfortunately, this is in your package, and I won't go through it all. But for example, chart reviews have been shown to have good reliability. They're fairly good valid. They're accepted by the medical profession almost as a gold standard. And they're fairly cost effective. However, on the other hand, they are time consuming. There's a lot of debate with regard to how many charts do we review, whether in the case of looking at a specific condition versus looking at care overall. And our colleagues in Quebec have been able to shed some light on that question. Not all aspects of patient care are covered. Chart reviews aren't really great for assessing surgical skill, for example. So, I mean, these are some of the things that you need to consider as you're going through in your discussions today when you're looking at each one of the cases. So, as you go forward with these cases, and Bill will come up in just a second to introduce those to you, I want you to think about why is this physician being assessed? What are the aspects of performance and which competencies need to be assessed? And again, thinking about that, the ACGME framework, as well as how do you plan to assess each physician? In other words, what are you recommending for the tools for that particular case? So I'll hand things off to Bill now.
Okay, thank you, and hello again. And we are going to stop talking now and have you start talking to each other and then reporting back to us, as Liz suggested. So we're going to go through two different cases and give you a task. So the first case, you and your group are taking on the role of the regulator. And here's the scenario. The scenario is that of a 72-year-old male GP, general practitioner, so he's not certified, works in a small town, falls off a ladder while cleaning his eaves troughs. I've come to find out that...
what do you mean by not certified?
Oh, so what I mean by that is that he is not a member of the College of Family Physicians of Canada, for example. So he's not a certificate. He's got a license to practice medicine. He's a general practitioner, as opposed to, we would differentiate a general practitioner from a family physician by someone who's passed their family medicine boards, essentially.
About just doing the family practice residency. You call that a GP if he finishes residency but not taking his boards?
Yeah, that would not happen in Canada, but certainly there are many physicians practicing in Canada of this age that would have only done an internship, and that we would call that a general practitioner. Okay, so he's cleaning out his eaves troughs, and I've come to understand that those are called gutters here. So we call them eaves troughs, but. And as I said, he fell off his eave trough and hit his head on the boot of his car. And so he suffered what's called an epidural hematoma. And for those people that are not medical in here, you can understand that that image is a CAT scan. And the large white blob that goes between 9 o'clock and noon is not a good thing. That's blood. That's called an epidural hematoma. And it's blood between the skull and the brain. And it needs to be managed by the delicate care of a neurosurgeon who drills a hole in your skull and sucks the blood out. So that's what this is not a real case. It's based loosely on a case, but so he suffered an epidural hematoma and also had a traumatic brain injury along with it, which one would expect. So 9 months later, he wants to return to practice, and for whatever reason you might want to imagine, he comes to the attention of the regulatory authority. So that's the background, and here's your task. How would you assess whether or not this physician is ready to return to practice? What would you want to assess? What tools do you want to use? What safeguards should be put in place maybe during that period and afterwards to make sure that patients are not being put at risk? And who should pay for it? So this is your task. We're going to give you about 20 minutes as a group to discuss these things and have you come back and report out, and we'll have a bigger group discussion about that. Is there any questions about the case or the task?
No previous problems with
No previous difficulties prior to this. Has been in active clinical practice since the age of 27.
And his physician has released him to return?
That's something to be discussed. So the question was, has his physician released him to return to practice? And that's something I think you need to discuss.
In terms of who should pay, is this situation in Canada or in the United States?
You can decide for yourselves where it's taking place and what you think is best, irrespective of the culture and the politics. Okay? All right, so we'll see you back in about 20 minutes or so, and we'll all be available if you have any questions and circulating around. Okay.
Not only do you have to do anything, so when somebody sends somebody to me, it's always done all my work. You know, not a physical exam, obviously.
Well, except for the fact that he's been out, psychological testing, physical exam, and then go deeper if we find an issue there.
In other words, we would want to have a mentor with him for a while.
No.
have any volunteers from any group to come up and just summarize what their thoughts were? Dr. Christensen. Thank you.
All right. First of all, our assumptions. All right, about this guy. First of all, we thought he went through surgery pretty well and he recovered pretty well. There weren't any complications. Correct?
Correct.
And he made a, and to everybody around him, his wife and his physician, he didn't have any particular problems that they could pick up, you know, that would be not expected by the neurosurgeon as he made his recovery.
I think you can have made any assumptions you wanted to.
I'm telling you the assumptions.
That's the assumption that you've made. Fine.
That's the assumptions we made. All right, and that his 9 months off were at the physician's request because that was the recovery of the
recovery and rehabilitation.
Recovery and rehabilitation. We weren't sure what he was rehabilitating from, other than the medical problem, whether he had other things. But we're assuming that he made a recovery of function. All right. So with those assumptions, and assuming a normal physical examination by his own physician.
Okay, so a physical examination would be one of the tools that you would want to use.
Yes.
To screen him for going back.
And the neurosurgeon's assessment also, because we are assuming that he would do proper follow-up of his surgery and everything.
Okay.
We then, after quite a bit of discussion, decided that we really, because he was in an isolated practice and there was a lot hanging on this if there was a mistake, that we thought that a neurocognitive examination was a reasonable thing to do in this particular situation.
Okay.
We then got into a lot of discussion about whether further assessment should be done. The neurocognitives, in my experience, are about $1,000 if you do a full one. If the next question was whether you did a full assessment, which is about $10,000 in most places. And it was our judgment that wasn't, well, I'm going to be biased. It was my judgment. I'm not sure everybody else agreed with me. So that if everything was normal and his wife wasn't reporting problems and that his doctor wasn't reporting problems and everything like that, that he could be monitored while he started practice by people around him, not special people coming in from the board or whatever. But if in any of this there was a problem, probably we would have a fairly low threshold to do an assessment.
Okay.
So that was our judgment. Now the follow-up, what safeguards should be in place, it seemed to me wisest for the board to to officially set a time to look into this again, maybe 3 months later or 6 months later, but administratively.
How would they do that?
Well, they would do it the way they did it in the first place. They got the problem. That they would just say, we're going to go look into this again in 6 months and then decide whether in fact we agree with this, assuming that we're going to interview the staff or the nurse or the doctor and everything and just make sure we were right about this.
Now, you mentioned having monitoring by local staff.
Well,
what would that entail?
Well, that would be part of what the board's responsibility would be to ask, and presumably his own physician would be asking. You know, in other words, do you notice any changes or differences in this person who had been functioning very well before? Are there any changes? It's a classic patient-centered thing. Are there things that he's doing differently than he did before? Is he forgetting things? Anything like that would, in our minds, would trigger a full assessment.
And who pays for it?
Pays for him.
He pays for it.
Right.
Okay. So in summary, then, you would recommend...
We hope that he had some insurance.
Okay. You would recommend an initial screen, and that screen is basically reports from the family doctor and the neurosurgeon that they're comfortable with him.
This is a safeguard. Once we had decided not to do the full assessment,
But,
in the
but
first
I'm
part.
saying right from the very beginning, what you would want is
Right.
that his family doctor and neurosurgeon are comfortable with him going back to work.
Right.
You would get a report from family members.
Well, again, that would be part of interviewing the physician and everything like that, who would
Okay.
presumably,
All right.
know the family.
And then a neurocognitive assessment.
Right.
And if the neurocognitive assessment showed no problems, given the fact that his premorbid state was that he was highly functioning, that you would allow him to return to practice being monitored being watched essentially by practice partners or
Practice partners or his own physician or his,
Right.
his
And
milieu that he's
the state medical board would then follow up with that monitor in some
Exactly.
capacity.
Right.
And if the neurocognitive assessment showed some areas of concern that were thought to be due to traumatic brain injury or minimal cognitive impairment, then you would recommend a full bore assessment, which is the big $10,000 assessment, multimodal.
that was
Okay.
our discussion anyway.
And he pays.
Am I reflecting?
You seem to have the support of your group. Okay, thank you. So we have another group? Rob? Wisconsin being overrepresented at the podium here.
I'm Rob. As always, I'm following Dick. Our group came up with the following in the domains that we were asked to discuss. First of all, it was what to assess, and we really wanted to make sure that his physical well-being could be verified, his neuropsych and his abilities to communicate were intact, and his medical knowledge and ability to interact with patients and synthesize information so as to provide good health care. The physical exam we talked about a little bit would be just something that a primary care physician could do, including a neurologic exam where you check cranial nerves and all that, as a very foundational starting point. If everything was going well from that standpoint, we recommended going on to a full neuropsychological exam, the one-day type of exam where all of the cognitive domains are looked at in detail, because he had a traumatic brain injury, and we're assuming if he was out for 9 months that there probably was a deficit for a while, so we felt we needed to go full-blown neuropsych evaluation after the physical examination, no matter what, basically so we can be reassuring before he goes back to practice. The tools that we talked about using for this would be to verify his medical knowledge and ability to interact with patients and synthesize all the information to make a good plan. We like the idea of him actually going back and looking at his old charts before this all happened and discussing them with him, a chart-stimulated recall on the premorbid charts, I guess I would call them, and discuss the care that he was providing, see how well he's recalling it, what his thought processes are, what his medical knowledge is. Look at all the domains that CSR looks at. Even though it wasn't recent, and we're not looking at this as his post-injury care that was given, we thought it would be very helpful. And if for some reason we couldn't get a hold of his charts, we'd do it Texas style and use redacted peer-reviewed charts and just discuss information and see if he can identify good and bad care. So I'm always going to throw that little soundbite in there because I like it. We also thought that it would be a good idea for the doctor to self-assess himself to see, does he perceive that he has any needs or problems? And I think it would be very helpful if he didn't think he was and we're seeing that he does. So looking for that gap analysis, which I think is particularly helpful from a self-assessment standpoint. And we also thought it would be important as part of this process to review his past and future plans for continuing professional development. Safeguards. We came up with almost the exact same plan that Dick did, or not Dick, your group, excuse me. We wanted him, if everything went well, we wanted him monitored for 3 months. And the monitoring, you have to forgive me because monitoring is done different in different places, but we loosely described it as intermittent chart reviews, maybe a phone call, maybe a visit to his office for observation. I don't know, but those are things that we threw out, but that's not rigid. When it comes to monitoring, I'm not even exactly sure what my own state does sometimes. Who pays? We said in an ideal world it would be nice if a fund could be indemnified to help do this, and we also realized that we had to give a realistic one, and we felt that in the United States, probably the onus would be on the guy who fell off the eaves or gutter. But we also kind of feel that maybe that's not the best way to do it, so it's somewhere in that spectrum. Now, that's considering that, that's assuming that everything went well. If things didn't go well, especially early on, with the neuropsych exam or with any part of his assessment, we would reflex it to a more full-blown, high-stakes evaluation. And does that pretty much sum it up, you guys? Anything I missed? Okay.
Okay, so it sounds to me like your group had a little bit heavier assessment on the front end than this group. I'm going to put you on the spot,
please,
just because I know that you are experienced and wise in this field. Would your or your group's position change at all if I told you that this doc was a typical old-fashioned country doc who still delivers babies, does the occasional appendectomy, works in Emerge, does all sorts of sort of procedural things as well? How would that change?
I would think that if that were the case, he had a very broad spectrum of practice, and I'm going to speak from me, and you guys tell me if I'm not speaking for us. I would probably want more skills verification or a more in-depth assessment to take into consideration his scope of practice. I think that the bottom line is the assessment does have to take into consideration the scope of practice, and if he's got a very broad one and in areas of high risk, I think that we would probably make it more intense. And ideally, wouldn't it be great if you could do direct observation for skills verification? But I think we also know the realities of being able to do that. So,
one of the things that's coming out that I want to point out is that I think a lot of people pigeonhole assessment into an event. And I think we have to understand the concept that assessment is a longitudinal process that takes place. So while we have to do the physical exams and the neurocognitive testing, while a physician is being monitored or supervised in some capacity, that's still a longitudinal form of assessment. You're still getting useful information from that process that informs you as you go. So this assessment process actually does take several months to complete. That's great. I think maybe we have time for one more group, and then we'll get on to the next case, just in the interest of time. Carol Rose, making her way to the podium.
I'm going to try to mention things that weren't mentioned by the other groups, and throw in some of the things that maybe just haven't been said yet. One of the assumptions that our group made was that he was released by his neurosurgeon, but the neurosurgeon wasn't making any recommendations as to the physician's competence. It was just a
Correct.
Surgeon's release. That was it. And the surgeon could theoretically have not even known that this was a physician, okay? And that the neurosurgeon said he had full clinical recovery, but that was clinical as if he was the milkman or whatever, okay? We want to know, is he on any meds? Is he seizure-free? Neurocognitive and behavioral was mentioned before. Now, one thing that we talked about is, did this physician have a pre-existing condition that caused him to fall off the ladder? Was he, did he have atrial fibrillation and he was taking Coumadin and fell off the ladder because of atrial fibrillation and had the bleed in his head because he was on Coumadin? So, you know, there's more to it than the story we've been given, quite possibly. Okay. Was he foolish enough to get on the ladder when he shouldn't have?
Insight problem.
That's right. We want a complete history and physical of this physician. We want to know whether the wife has come to the board and said, please don't give him his license back. and I know that this kind of thing happens with, it could be anyone, whatever their whether they're a physician or not, that the Department of Motor Vehicles has family members coming and saying, please don't give my father his license again. Please don't give my husband his license again. So that kind of thing could be in effect here. And then we would be recommending, if possible, that he not work solo. That was also mentioned. A monitored practice was mentioned. When we very, very briefly had a moment to discuss who pays, those from Canada said the board pays. Those from the United States said the doctor pays. And I know that I see from the Pennsylvania Board of Medicine consent agreements that mention a lot of these things that not only our group, but the other groups have also mentioned. A consent agreement of this is how it's going to be handled over what you're talking about, an extended period of time.
Thank you. One of the things that was not brought up in this group was brought up in the previous group was the question of why he wants to go back to practice at all. So at age 72, because it may be that he's going back to practice because he's got financial need. It may be he's going back to practice because he's in a small town and he's the only show in town, and he feels a professional duty to his patients, so doesn't really want to go back to practice, but feels that he should. And if that's the case, maybe he's going back prematurely. So those are some other things to consider, I think, in an intake process for a physician like this. Well, that's great. So I think we will. I'm going to move, but just slightly because I'm tethered. We're going to just talk about the next case. And the next case isn't really a case. The next case is building on what you worked on in the first workshop, which is the concept of screening. So if we can agree, even if we can't agree, just run with me, that aging physicians are at greater risk for performance failures and disciplinary actions based on what you heard this morning. And therefore, it's reasonable to think that mechanisms should be put in place to identify physicians at risk of the above, so performance failures and disciplinary actions. If that's the case, then we want you to design what should be put in place for a screen. And I want to highlight the term screen. We're not testing physicians here, okay? So this is not a pass-fail testing thing. It's a screening process to identify physicians that might be at risk in this particular age group of getting into performance difficulties or potential for disciplinary actions for whatever reason. So what we want you to consider is when you would start this, meaning at what age, how often it should be done. You don't need to consider all these. It's a lot to think about in 25 or 30 minutes. But what it is that you'd want to measure, which aspects of clinical practice should be assessed. So is it more important that you assess psychomotor skills versus communication skills? What tools or instruments would you use to do that assessment? So this is a broad thing, so in all likelihood, it's not likely that you're going to be doing direct physician observation for a process like this, but maybe you want to do that, so you can feel free to suggest that. Who owns the results of the screening process? Who should actually do the screening, and at what cost, and who should pay for it? So those are the things we'd like you to consider in your groups and report back just as we did. We're going to give you about 25, 30 minutes for this, and we'll come back to talk about that and then to do a wrap-up, and we'll have some interactive questions as well. So are there any questions about the task? You're such a good group, or you're so tired. That's good. All right. So we'll see you in about half hour.
It shouldn't affect his practice afterwards.
I can feel there's a different energy in the air, and I think that different energy in the air is because the day's almost done. Dinner's coming. Dinner's coming. It's been a great day, and I want to thank all of you for your contributions. We want to hear from you about what you thought about this issue of screening. You are probably are advantaged in this case over the other workshop group because you got to do that whole discussion debate about the screening before this. So you're well versed in it. You know all about it, and we've got high hopes and expectations for your reports because of that. So. Gina, your group, can we hear from you? Is there someone from there that could you're going to speak to that? Great. New medical advisor at the College of Physicians and Surgeons of Ontario. Brand new. Dr. Gina Piliotis, hematology oncologist.
Okay, so we got a little off topic and started chatting more than attending to task, but I will try and get through all of this. So, part of our discussion was flopped back and forth between what we would do with an unlimited pot of money in the ideal world and all the assessors that we need, and what would be a practical thing to do. So, my answers will be a little back and forth as far as that's concerned. So with respect to when to start, I think we discussed in the ideal world, we would start when people enter practice as far as everyone gets the same baseline screening assessment, and it isn't really age related. But if we had to be age related from resources, that 70 we think is probably a little too late. 60 may be practically too early, so maybe 65 would be a better number. But again, that's a resource issue. And as far as intervals, again, as pilots, they get, these full simulation, et cetera, assessments on a yearly basis. Again, probably practically not possible. So we thought at least every 5 years would be a starting point for a practical thing. As far as what to measure, we talked a lot of different things. So if we could do a baseline, very broad-based capture as many possible issues. In other words, have no false negatives, and we don't really care how many false positives we have if we're in a non-punitive educational type of environment. We should actually allow a whole lot of false positives so we don't have any false negatives, so it's a real blanket. But whatever it would be in a clinical practice. So we did talk about things like peer assessments, things like the peer assessments being a peer coming into your practice and doing a chart review, 360 evaluations where you interview or send out surveys to other physicians you work with, patients that you work with, people that you refer to, et cetera. We thought all clinical environments should require assessment. Instruments, I guess I talked a little bit about what instruments that we would use. Other things as far as instruments that we talked about is if there were decent databases where we could actually pick up very broad-based or low-level type of information, like prescribing information, where you could look at everybody's prescribing on a certain issue every year, that sort of thing would be ideal. But of course, you'd have to ask what specific questions are you going to ask, because you could ask hundreds of questions, and then it actually gets more costly than the peer assessment. So you have to pick and choose. Ownerships of results, we had a predominantly, or at least half Canadian group. So again, and that comes to when we talk about costs, that'll come out too. But as far as ownership of results, we definitely felt that it should be owned by the licensing body, whatever that body is, with obviously the physician having copies and access to the results from the educational side of things, but it should be owned by the licensing body. As far as who should do it, we didn't, again, from the Canadian perspective, it is the licensing bodies that predominantly do this, but in the American side of things, where the licensing bodies may not have the funds to be able to do this, if there are outside organizations such as PACE and the other ones that we've heard about that can do that in a standardized fashion, but then the results would that still be owned by the licensing body. And then at what cost? Again, I think from the practical side of things, we can't really do the full practice assessment like a pilot does every year, because we know that it's easier, not entirely simple, but it's certainly easier to simulate multiple things that happen in an airplane, and not so easy to simulate what happens in a physician's office. So I don't think we could ever really do a full comprehensive assessment on a yearly basis. So we always have to balance that. How much is it going to cost the system or cost the physician versus having enough of a comprehensive assessment. So we didn't come up with a really good answer as to at what cost, to be frank. So.
Okay, thank you. Just want to talk just very briefly about the concept of screening over time. I think it's a neat concept of screening all physicians on a regular basis, and because I think screens are something that can be used to be compared against a norm, but you can also use screens to compare a physician to themselves over time. And it's something that hopefully we'll be able to do a little bit better as we get more technologically advanced with electronic record, and we can actually pull out bits of data that are meaningful or that we find to be meaningful. I can't believe that I'm a Canadian and I've been up here talking pretty much all day, and there hasn't been a single hockey reference. So I've got a nephew that plays hockey, and he just had a concussion a few days ago. And his team at the beginning of the season, like many sports teams, undergo baseline neurocognitive assessment. He's 12 years old. And so they all have neurocognitive assessments done at the beginning of the season, so that if they get concussed, they then go through the same screening and they can look at what their progress is. Wouldn't it be a nice world if we could do a similar thing for physicians and have a baseline screen based on data, based on outcome indicators that we can pull from databases, and then do that on a regular basis so that we can identify where physicians are starting to get into difficulty, be that related to age-related problems or whatever. Problems. So it's someplace that we need to go, and we need to be advocating for the systems to be built that allow us to do that. Okay, we have a mini group here. Have you got someone that's gonna report back for us? They had 4 strong individuals in their group.
Yeah, that's true, and 3 from the Canadian regulatory part of things, and 1 American attorney. So.
Oh no.
Yeah.
Fly on the wall.
Galt Wilson, I'm from BC. Just briefly, because there's a lot of overlap, but the emphasis, we kept bringing ourselves back to the fact that we're talking screening, and it's so easy to flow into assessment, I think in part because for many of us, the screen has, we've attempted to be as comprehensive as we are with our assessments, and that becomes expensive and difficult to organize. So when to start, 70 is sort of the emotional and pragmatic age, but a baseline assessment somewhere between 55 and 70. We were impressed by this morning's speakers. There seems to be an inflection point at about age 55 when the fish start to appear. The intervals, I think the main theme there, it was pointed out by actually the non-medical person in the group, that after age 70, health status can change abruptly. And so from a public person's perspective, every 5 years after the age of 70 seems like a long time. What to measure, we actually, the instruments and what to measure, not because we were warned that we shouldn't be driven by the instruments, but it all seemed to glom together in our discussion. But we want to, our bottom line is the multi-dimensional, we call it CanMeds in Canada, and the American equivalent. We want people to be clinically competent, but also collaborators and communicators and managers and so on. The environment, let me park the environment and go to instruments, because the feasibility issue, there are going to be a lot of individuals over the age of 55, and if we want to screen in a way that's sensitive, where's the last person, that we don't miss anybody, we have to cast a wide net. So our emphasis was on electronic data collection to the extent possible from data sources that are gradually accumulating. And for example, in BC, we have the prescription database. Every prescription dispensed in the province is potentially available to us, and there are various things we can glean from that. The billing database, not quite so good because there isn't a lot of accountability as to the accuracy of that, but there are growing numbers of databases, and I know Quebec is very rich in that area. Where there aren't existing databases, but we want to gather material, let's let the physicians do the work to the extent possible. It's very expensive for the bureaucracy to fill out forms, let alone our physician contractors. So people who are going to be the subject of a screen should sit down at their home computers and fill out extensive questionnaires, and the advantage to them is that it's standardized. It won't be somebody with a pen in hand interpreting their answers. They'll be answering the questions themselves. There was agreement to that whole aspect of carrying and face validity. 360 type instruments are the way of the future and will be part of it. My final plug in terms of instruments is, and I don't know if we came to consensus on this, but in our environment, it's very difficult to recruit physicians for any money. We've been busy expanding the size of our educational programs, the undergraduate and postgraduate, expanding the roles of physicians in various aspects of healthcare. And when we go looking for physician assessors, even for money, they're not available. We've talked about a shortage of physicians. So I'd like to see us exploring much greater use of non-physicians. And that, I think, dovetails nicely into the need to be consistent and objective. And so my image is a non-physician surveyor who comes to the office with an iPad and a bunch of check boxes. And they pull the chart, and are these elements there, yes or no? They look around the physical plant and so on. So those would be the themes of the screening program. Ownership, is that to do with formative or summative? What are the consequences? Everyone in the group agrees that it has to be explicitly QA and non-threatening. The licensure doesn't hang in this balance. And at what cost? At least where I come from, the regulator does bear the cost. The physicians will share it together. And the sort of political rule of thumb for us at the moment is that the tolerance is somewhere between $100 and $150 a year, maybe. We haven't quite convinced our colleagues how much they should spend on this. Before the economic disruption in 2008, our government was just swimming, and I mean, we should have got them to commit to funding this.
Thank you. Liz, I wonder, would you feel comfortable just addressing the issue of non-physician assessors? We looked at that at the college, at the CPSO a few years ago. Why don't you come up to the podium? Am I putting you on the spot? Is that okay? Yeah, that's good. Okay. All right. We used some non-physician assessors, nurses, I think they were, to do CPSO or physician peer assessors, and had a little bit of experience with that.
Yeah, this was specifically around using nurses to do chart assessments. And what we found, we actually had physicians do the chart assessments and nurses. And what we found most of the time was that the nurses tended to err on the side of caution with regard to care. So they were more likely actually to be critical of the charts that they were looking at, whereas the physicians were more likely to be lenient. The sort of the comparator that we had on this was the actual adjudicated response that was looked at by the committee, and more often than not, the physician who was doing the chart assessment was likely to miss true positives, whereas the nurses never missed them. So actually, to be honest, they were actually better at reading the physician's charts than other physicians were. So that's something to keep into consideration, that when resources are scarce, as much as having a peer for interaction is valuable, there are other qualified health professionals who are able to assess quality of care and who also may be more willing or more able to give the time that's required to do some of these activities.
And the problem with that model, though, is that it does take away from the perception of credibility from the physician's perspective, because most physicians feel that only another physician can look intelligently at their practice.
I think the key there, though, is we're talking about screening, and it's a screen, so anyway, I think that's the answer to all of that.
Right.
It's low
Right.
stakes.
Good point. Good point. Okay, I think maybe we have time for maybe one more group to report out before Peter comes back with our interactive session. Is there a group that wants to share? Yep. Well, we've got an enthusiastic group over here.
Yeah, they're pushing you forward.
Pushing you forward.
Okay, so in order for us to get warmed up and started, we first had to debate the premise a little bit before we could really get into this. But then we accepted it, that we were going to accept that aging physicians were at greater risk, and so that we needed to have a screening system in place, and we were going to consider these factors. So again, our group, we had in when to start, there were some who thought it should start as early as 50, and then there were others who felt it should be 70, but as we discussed the issue, it seemed to narrow down that somewhere between 65 and 70 ages, that there should be a screening system in place. The intervals at that time, we agreed to 2 years that we felt would be protective and cost-effective. In terms of what to measure, what we were focusing on were the risk factors that were discussed this morning during the various presentations. So we wanted to assess things like the number of patients the physician saw each week, what that person's area of practice was, whether they were in solo practice or in group practice, whether they had hospital privileges, whether they had changed their scope of practice, whether they had taken continuing education. So those were some of the things that we were looking at. And what we were thinking was that we would do it either through a questionnaire or if there was a database available. So ideally, if when, for example, the physicians register their licenses or renew their licenses, if these were items that were already available, then they could be drawn from the database, and that would be a very cost-effective way to do it, and possibly could even go back and look at, what the earlier practice had been. We didn't understand the question, what clinical environment should require assessment, so we skipped it.
Okay.
The instruments, the database and questionnaire. In terms of ownership of results, we felt that should be with the licensing body. And who should do it? Also the licensing body. The cost we also felt should be licensing body that was taken through the medical licensing fees that had been paid.
Okay. So from what I understand, what you're describing is a system whereby for every physician who's over the age of between 65 and 70, a screen is applied that essentially looks to identify other risk factors in those physicians. So other risk factors being solo practice, change in scope of practice, all those things that you listed off. And that from that group then, if they have enough of the risk factors, then
we move on to that
what?
group's assessment procedures.
Okay, so then you actually do an assessment of the physician.
Then we go to Gina. Yeah.
So then you do an assessment.
Yeah.
So essentially, this is, I see Andre over there smiling proudly
great
because
coach.
this is the Quebec system essentially of assessing physicians who meet certain criteria based on risk factors. But what you're doing is that the common denominator to get into this system is age, and that you would apply that tool every couple of years in case something has changed in their practice. So if at the age of 72 they're in solo practice or they've changed their scope of practice from family medicine or neurosurgery to walk-in clinic medicine, then that would also be another flag. Is that right? Okay.
Precisely.
Thank you. Okay, that's great. Thanks, Andre. Those are all great. It's a difficult area, clearly, and it's one that is contentious from the physician's point of view, is costly, and one that's probably going to become increasingly necessary based on what we learned about the physician demographics. So hopefully we'll see some movement in this area, and we'll all be able to do some more creative things. No one's got a perfect system. Okay? We're all working on it. Peter, I think Peter's going to come up, and if you can grab your remote controls. As I said to the last group, if there's anyone that doesn't know how to use the remote control, if anyone's confused by it, then Bill Norcross wants to see you at the PACE office at 9 o'clock tomorrow morning. So there we go.
Okay, so everybody knows how to work the remotes. I don't need to go through any of that. Please indicate your level of agreement with the following statements using the following scale. And the polling is now open here, but medical knowledge is important to assess in aging physicians. 1, 2, 3, 4. How strongly do you agree? And you can only choose one. I'll give you guys about another 15 seconds. Okay, I'm going to close the poll here. Let's see how we felt. Okay, strongly agree. Great. All right. 3% strongly disagree. Interesting. Okay. Well, we've got almost 99% of some level of agreement, so that's good. Okay, so patient care is important. How important? Let's see. Okay, we're going to close it because now I know exactly how many people are polling, so this is easy. Okay, let's check this out. Okay, 79% strongly agree. And what was the last one? 61% strongly agree. So here we go. Huge agreement on patient care. And one disagree, but no strongly disagrees. Okay. Practice-based learning is important. Let's see. Oh, somebody else picked up a remote. I got a 34. Let's check it out. So, no? Okay. Well, not feeling as strongly about it, but definitely a high level of agreement, but also some more significance in the disagreement there. Okay. About interpersonal and communication skills. Let's see how we feel about that. Somebody's, all right, that's, all right, well, anyway, we're going to close the poll. So if you didn't press the button, too late. And here we go. Pretty high there. So far, I think patient care is winning. All right, professionalism. How do we feel about that? What does that mean? That's why it's not there. There is no neutral, purposely. You have to take a side. Commit. All right, we've got everybody pulled, and we'll close that. Little more split, looks like, on professionalism. Okay, some of these ones I think a little more difficult to conceptualize how to do it, and that's, I guess that's to be expected here, a little more division. Okay. Well, let's go to the last one here. Systems-based practice. How do we feel there? Another few seconds. Somebody didn't press. Okay. Well, we're going to close it. And let's see here. Yep, kind of split again. Okay. Well, that's certainly interesting. Okay, how about physical health? Is that important to assess in aging physicians? Another few seconds. Okay, we'll close it. And wow. All right. So 85% at least agreed, and then no strongly disagreed. So pretty high consensus there. Okay. How about cognitive function? People think that's important to assess in aging physicians. Wow, you didn't waste any time answering. We're done. Let's see. I'm going to guess yes. Yes. Wow. Okay, 3% disagreed. And that is so far the strongest answer we've seen. Okay, not too surprisingly. All right, how about mental health? How do we feel about that? Is that important to assess? Yes, it is. Okay. High again. All right. Now, this is going to be specific to the case one, a for-cause assessment. And please indicate which tools you would recommend for the physician in case one. And I believe in this instance, you can select more than one. So you won't be able to tell from your remote which ones you've pressed, but you can press multiple. The case one, sorry, the for-cause assessment, the 72-year-old general practitioner who fell off the ladder. Yeah. Yeah, so you got to go back to remembering that case a little bit. I'll give you guys 30 seconds or so to think about it. Maybe that's more time than you need. Okay, we'll just move on. Looks like we've got about all of you here. So let's see what the distribution looks like. Oh, interesting. Okay, so interview, stimulated recall, tops the list, and then, wow, really even with chart reviews, direct observation, and standardized patients. Okay. And then less on the peer review ratings and patient ratings. Interesting. Definitely interesting. Okay. And this is actually just a continuation of more tools that are available in that first case. Sorry, it just was harder to fit all on one slide. So these are more tools that are available. So if you feel that any of these would have been useful, go ahead and select those too. Great. Looks like everyone's answered. Cognitive function. Okay, well, that we already knew. So that sticks out. And physical health, number 2. Self-evaluation. And interesting. Okay, great. And then now, going to case 2. This is a screening assessment only. Which tools would you recommend for this scenario? This is the scenario as a screening assessment for an aging physician, not for cause. So if we heard the ranges anywhere from like 65 to 70. If there was going to be some kind of mandatory screening done for an aging physician, what tools might you select? None? Okay. Well, I'll give you guys another few seconds, and then we'll go to the next slide, because then there's a continuation of the same elements that were on the previous slide. So I'll give you another 5 seconds. Okay. So there were, by the way, 25 responses, and so here's what the percentages look at. I think there was 33 or so of you in total responding. So we had 8 that didn't put anything, but distribution, okay, chart review and peer review rating surveys are the highest there, followed by the patient interview. Okay. So then here's the continuation of that list, and this is again for the screening only, not for cause. Give you guys another 15 seconds. Okay, let's close this. 24 responses on this, and we'll see how it breaks down. Self-evaluation number 1, or tied it, I guess, with cognitive function. Interesting. Okay. Well, great. Well, we thank you guys so much for providing us with your feedback. I can tell you it was different from the other group, and no, I think it's interesting. When we originally conceived of these workshops, we had thought that it would make sense to have the workshop with the point counterpoint precede this, to kind of give you that chance to discuss the idea of doing a screening assessment for an aging physician. And they didn't get to have that discussion beforehand. So a lot of their discussions involved debating whether or not this is something to do. And so I think logistically it was going to be a challenge for us in the space and so we just decided to kind of break the two up. But I think it did yield some different results in the discussions that you had, and you were definitely a lot more focused in the small group. So it's interesting to see how the results changed too. So thank you so much. And Bill McCauley, did you want to say anything else, or